My presentation about amputees, just because I went to Excel and I think I observed 21 hours in total, and most of their patients were like amputees, but not all of them. I saw mainly amputees though, so that's kind of why I wanted it. And I really wanted to do it because Optimus,
Yes.
Optimus came to our school and gave a whole presentation about prosthetics and how to treat amputees, and that's why I wanted to choose this. Is this bright enough?
Yeah.
First off, I'm just going to start off with the common causes of amputations. The first one is PVD, peripheral vascular disease. And then IDDM and cancer. A lot of they start with wounds at their feet, and then it just goes up, and then hopefully they don't have to get, that's what depends on whether you have below or above knee amputation. And then the second leading cause is trauma, like motor vehicle accidents, gunshot wounds, or working on a farm.
Oh.
I saw that. I was like, oh, that's interesting. And then the third is congenital diseases. And I also read that there's more amputations needed for upper extremities rather than lower extremities for congenital reasons. I would have personally never known that, but I thought it was interesting.
I didn't know that.
And then the two types of amputation are below knee and above knee. It kind of depends, the main goal is to preserve most of the leg. I've even had, when I observed some patients are like, man, I wish they would have just cut my knee off.
Mm-hmm.
But it's really way easier to recover from below the knee because you still have more function.
Right.
And it's going to be easier to regain strength if you have more of your leg.
Right. Yeah.
Above knee amputation is also known as transfemoral, and below knee amputation is also called as transtibial. And I already said both of them have a lot of the same exercises, but they differ in just a little bit. I'm trying to think. There's another slide, but they're very similar, but some things are different. There are also different types of prosthetics for each, but again, I feel like that's assumed because you have a big socket for a thigh versus for a calf. So, and then I can scoot this a little bit closer if you want to see. This is talking about a transtibial amputation, the different levels. There's also called a Symes amputation. It's right here.
Yeah.
And I'm pretty sure that one is when maybe not that one, but there's one amputation where you can preserve the heel pad. And it, they can be way more functional with the heel pad. So, and then I also included the foot amputation levels just because that Symes, the heel pad is right there. Mm-hmm. I just thought that was interesting because, I feel like you could still be functional without your toes, but then you think, could I?
Balance.
Yeah.
Have you ever seen one of those?
No.
That's okay.
No.
Mm-hmm.
I've really mainly only seen above and below knees.
Okay.
But when Optimus came and, taught everything, she showed us pictures. And, seeing the pictures, I was like, oh, well,
We
probably
did
would.
guy with his toes.
Oh, really?
Yeah.
And then managing a new amputee. Some of this is based off a PowerPoint that Optimus provided, so it's actually what they do to provide the prosthetics. But the three main goals after amputation, obviously maximize the patient's physical and psychological rehabilitation while minimizing physical discomfort. So, I feel like you feel like you lose, you literally do lose a part of yourself.
Okay.
But it's hard for people because then they feel like they can't walk and they don't want to do anything. And a lot of people are very guilty about not wearing their legs. I saw a PT eval and the lady was like, yeah, I wear my leg all the time. And the PT was like, all right, can you put it on for me? And she's like, well, she couldn't.
Wow.
So, but I saw her progress too.
Yeah.
So that's good. The second one.
Did they just find it easier to stay in the chair?
Yeah. Well, a lot of them, obviously it's a new thing, so it's very uncomfortable for them. Right. And a lot of them aren't doing, the proper wound care, and they're not doing the shrink or wrap.
Right.
And, some of them will just be like, oh, it's not the right size. but then they're not using the plies or the socks that you could
Right.
put on, so it's never really perfect for them. So then they're just like trash the leg.
Yeah.
And a lot of them actually get like quite expensive legs, like especially knees, power knees. But they're like, no, I don't want this. No, this is a piece of crap. We need to get reevaluated and all that stuff. Oh, edema control is also very important. Again, with the shrinker wrap, some of them are compliant with the shrinker wrap, but I mean, I feel like someone really has to sit down and be like, hey, this is why it's beneficial.
Right.
Like, you have to do all that stuff even before you order the leg. And the leg takes 6 to 8 weeks to even be made. So it's like, you got to do it. And then during the healing time, waiting for the prosthetic, is crucial. Maintaining range of motion and all that strength and stuff, because, you want to be ready for your leg when you get it. You can't just sit around and wait for it, because then you're more prone to contractures and you can't walk on a weak leg. Yep. Oh, I'm not going to go over all the prosthetics just because there's like one for everything under the sun.
Right.
But there are multiple different types of prosthetics depending on what the patient specifically needs. And it also depends on whether it's above or below knee amputation. But there's a osteoarthritis knee unloader brace. Like there's 2 right here and 1 right here. Like, like a hinge knee brace, but it's specific. There's a lot of specific ones. I'm not going to go in depth because then we'd be here for like 13 hours. But a lot of patients do end up complaining that they don't like their leg. And I mean, some patients' legs don't really fit. And that's just like, they thought the leg was going to be bigger, like, because they mold it and everything to make it like perfect for the patient. But, sometimes patients lose weight. There's nothing you can do.
Yeah.
Sometimes they gain weight. So,
But don't wear the shrinker.
yeah, the shrinkers are a big thing because they don't want to wear it.
Yeah.
And another reason why they don't want to wear prosthetics, like right now it's like 88 degrees and they're like, girl, I'm not wearing that thing. And I'm like, truthfully, I don't blame you, but you really need to.
Yeah.
Always put it back on there.
I was thinking about having that leg that you had in there, but like just the components.
Yeah.
Just for the components, like the socket is like where this part of the residual limb goes in, and then the metal bar is the pylon. Yeah. And then the ankle and the foot. One of the most expensive components is the knee, just because it can be mechanical, it can do everything for you. It can be, what's the word that I'm looking for? I'll come back to it. But that's like one of the main challenges that they have to overcome, because you watch them gait train and they're just using like a vaulting gait because the foot's not going to clear the ground because they can't bend that knee.
Right.
So we normally do like, they have a little step and they put it on there, but the main thing is they don't like contact during heel strike. So I have to like make sure they do that and then push off with the heel of their foot, because it's just really hard to get them to do, because then they think it's going to buckle, but it's really just bending.
Yeah.
Because, it's like not part of your body.
Right.
So it just be kind of weird.
And swing gait. I see a lot of swing gait.
Yeah. I also saw that there's a thing, I thought it was called a spastic gait, but it's just like when you walk with a stiff leg, so it's not technically a spastic gait, but I mean, when you're walking like this, it's kind of stiff. The shorter and weaker the residual limb, the more mechanical support needed, and the longer, just what I was saying earlier, if your leg amputation is right here, you're going to have to need less support because you have more of your own body and more of the awareness. The important in knowing which prosthetic to get and what the amputee needs. That's where the processes come in. That's not really what we need. I mean, the part that we can play in is they're walking and maybe the prosthetic is like way too high and they're not level, then that's when we can come in and refer them back there.
Right.
Sometimes we can do it, but they normally have like a set of tools that they can use it themselves, and they normally don't bring it to therapy.
Right.
So, I mean, they can if we remind them, but we are allowed to like adjust it if needed. But sometimes people don't know how.
Right.
That's why it normally doesn't get done. Oh, all the different types of prosthetic designs, transtibial, transfemoral, partial feet, cymes, disarticulations, bilateral, juvenile, geriatrics. These are all very like general. And then recreational, sport, veteran, obese, and upper extremity. Like a lot of people like don't really like know their function, but they're like, I want one of those prosthetics that people run with, like the little metal bar, but they can barely walk. Yeah, so it's just kind of like you got to know your patient.
Right.
Oh yeah, and I already went over the components of it are the socket and suspension. The suspension goes down right here, and it's just like to make sure your leg is all the way in, because some people have I don't know if you've heard of the air socket in seal, but they have to like get up and they sit down on it, and then they unscrew it right here and let all the air out.
Oh, okay.
And there's a little hole, and you can see where the leg is right there to see if it's actually far down enough.
Okay.
Those are very popular because that one and the pin lock one, so where you can hear it go.
Yeah. Yeah.
So like for people who are like less there,
right,
they can hear it.
Okay.
So all the general categories on the left have multiple different types of prosthetic designs and can get very specific depending on what you need. This is what I would have showed you, but socket, knee joint, pylon, and foot. Also, the prosthetic designs like depend on, are you super concerned about people knowing if you have a fake leg or not? Because some people, the people who want to do sports, they'll get the little hook.
Yeah.
But people who actually care, they'll get those regular feet, and they'll make it look like a real leg as much as possible because they would rather look good than be comfortable, which I can understand from a point. From a physical therapy point, maybe not so much.
I don't like a design.
Yeah, I mean, I've saw a lot of people have like Cincinnati Red sockets, and they're like, I can't wait to switch this one out. Common gait deviations, just from my observation of the 21 hours. Excessive retroversion. They're penguin stancing. It's almost with every patient. Limited weight shifting on the prosthetic leg. They're scared to do it because they think their knee's going to buckle. Best way we start them off is the parallel bars. But even then, it's like they don't want to do it. Decreased stance phase on prosthetic leg. They all have really bad genu recurvatum. So like when they walk, it just snaps back and it like scares them because they think their knee's buckling, but it's actually going back. Like, I mean, I stand with genu recurvatum, but they're stops and then it snaps and then they lose their balance. So that's another thing that we really have to look out for. Genu valgum. They do really bad knock knees too, which is weird because, knock knees and excessive retroversion, it gets kind of crazy. It's like, which thing should we work on first? Oh, the vaulting gait, like we talked about earlier, they just want to get that foot up rather than, some of them have stairs at home, so they have to, it's really hard for them to unlock their knee. Common rehab exercises after, like, the amputation, not like when they're trying to use their leg, like when they're just in bed, glute sets, ham sets, hip extension. You can do hip extension in supine, prone, sideline, whichever like you're advanced to, but that's very important to prevent contractures. And then just lying on your back or lying on your stomach, like while you watch TV or whatever, just to, give everything a good stretch. That goes for both of them. And then bridging, that's a good one. Core strength to help balance. hip adduction, just put a towel in there and squeeze. Hip abduction, supine, sideline, whichever one you're advanced to. And yeah. Oh, sitting. Sitting tolerance is hard for them at first as well. But also once their sitting tolerance is good, then you can start doing the chair push-ups and all that stuff because, more than likely after the amputation, they're going to need something to wheel themselves around, and they need the arm strength for bed mobility and all that stuff. And standing balance. And then the below knee amputation rehabs are basically the same, except we include straight leg raises, knee flexion and prone, knee flexion and extension, just sitting to get that knee motion so this knee doesn't, the prosthetic knee doesn't lock up. And then chair push-ups, those are always a good one. This is after, once they have the prosthetic. Weight shifting, balance, on the parallel bars and then just by themselves, one hand, no hand. Unlocking the knee, like we talked about, it's a big one. Gait training, getting residual limb into the socket and making sure it's far enough. That's really hard because then they won't walk right if it's not far enough. And that's easy with the pin lock. And then putting prosthetic on, making sure they do all of it, use the correct amount of plies, use alcohol, because some of them aren't all the way there, so then they don't remember to bring all of that. And then it's okay, if you can't do it here, then you probably can't do it at home. Small hurdles, just to even if they are doing the vaulting gait at first, they need to learn how to lift that leg. And then steps, just a little curb step like we do here, just increase as time goes. And then we, specifically at Excel, we did the AirX square like we use, but then we also use long rectangle AirX pads, and we put 2x2 and they walk. And then they do some side steps. That's the hardest exercise for them. I've never seen a almost go home amputee do it easily. So it's always a challenge. It's a struggle for me too.
Right, it's all uneven.
And then psychological effects, mental health, grief of losing a limb, depression, anxiety of falling, decreased confidence. You might think no one wants to hang out with you. You probably feel judged, stared at when you're out in public. And then phantom limb pain syndrome. I had a patient who had phantom limb pain syndrome, and he was like, "Is it raining outside?" And I was like, "I don't know why." And he was like, "Because my foot's acting up. I can feel my foot." And I was thinking you don't have a foot. But he was like, when it rains, it immediately, as soon as it starts to rain. And I thought that was so interesting. Because I was like, I didn't know that. But now I'll know. Common misconceptions about amputees. Amputees can never participate in high velocity exercises. A lot of people think if your leg is amputated, no more sports. Just depends what your goals are. If you're 85, you're probably not going to run a marathon. But if that's a goal, then we can try to get you there. But amputees will never walk normally again. I feel like a lot of people think that, but that's not true because we're just giving you a fake leg. It's not like we're not giving you a leg. They cannot go back to work. I actually read an article where they were weird. I don't know if you can do your job as well as you could. But that's when you contact the ADA and say, listen, you cannot, this is discrimination and all that stuff. Because I feel like a lot of people face those issues, which I didn't think that would even be a thing. And then amputation only affects physical health. Like I just talked about, it really affects your mental health and how you view yourself. Maybe you think you didn't take care of yourself well enough or something like that. I've had a lot of patients express me, they're like, I'm just a failure and I didn't take care of my leg well enough. And you just gotta hype them up and say, you're good. Your life will stop after having an amputation. Same thing. It doesn't. You just have to work towards your goals. They must have a traumatic accident. Some people think that. I'd hope people in healthcare don't think that.
Right. Yeah.
But a lot of people don't think that a wound on your foot could be anything.
Yes.
And I feel like that's not okay.
Mhm.
But and then the last one, amputees only have to wear their leg when they're out and about. That's the biggest misconception. I feel like people think as soon as amputees get home, they're like, you
Yeah.
have to be, like, once you're able to walk, you have to be wearing it all the time in
Right.
order to get back, because that also, you know, your shrinker doesn't do all the work.
Right.
Your leg is also help shaping that residual limb, and yeah. But that was it.